Okay, so let's get this started so that we can get the recording in on time at least.
Yeah, for sure.
So thank you for doing this.
Sure.
You went and you were a classmate of mine, Ale. You went and you actually did the internship and you became a registered dietitian. So congratulations on that.
Thank you.
So today what we're going to talk about is disordered eating in athletes. You said that's a huge thing that you come across. So if you could just kind of elaborate on that for me, please.
Yeah, so well, I am specialized in eating disorders, right? So it is a different thing than disordered eating, but it often leads to eating disorders. So what I have noticed a lot in the last year or two that I've been doing this, especially when I did have just solely working with college athletes, is this terrible relationship with food. Although they deem food as a means of success and performance, they become afraid of a lot of food. So it becomes a kind of compensatory behavior towards food. So it's kind of like where I see most of the.
And that's what you're saying is disordered eating, correct?
Right.
So what is the difference between, because you said that although it's not the same, what would be the difference between eating disorder and disordered eating?
Yeah, so it's tough to really, like, unless trained, to see really the big difference because they both have a little bit of each other. So when we're thinking about disordered eating, we're thinking more of like isolated habits that don't take up a lot of their life, right? So it's things that we see, like you and I see all the time since we're trained in seeing, there's always a new weight loss fad. There's always kind of like, oh, I'm going to do this one diet because I want to lose these pounds before Christmas or before this or for the summer. And these overall are not necessarily eating disorders because it happens that they can still, for example, go to a restaurant or go somewhere and they don't necessarily have to freak out about the food, or they don't avoid social gatherings because of the food context. They usually have these kind of habits where they eat too much when they're bored, or they avoid eating a specific macronutrient, like, the keto diet, where there's like, they stop the carbohydrates because they think that that's going to help them do this. When we move towards more of an eating disorder, it's a mental illness where not only is there could be like body distortion, there's also a very big factor in how it becomes an over consuming thing in their lives. They're not able to do anything without overly thinking about every food or every event, and it usually has occurrences of mood disorders, a lot of depression, anxiety. So it's very different in the quantity of these habits. So disordered eating is more like select moments in their lives where it's like they wanted to fit into a dress and then they did something
and
yeah,
makes sense.
Exactly. Whereas when we come into an eating disorder, it's more of like these habits are all consuming and are very often.
Okay, so disordered eating would be pretty much kind of like a seasonal thing for an athlete, since we are talking about athletes.
Yeah.
So it would be as if someone's training for a game or for example, for a wrestling match. Those tend to have to like, they drop weight to make weight for a class versus an eating disorder is someone that might suffer from some type of mental illness, and it could be prolonged into it could have been from the very beginning of their life to up until the end, pretty much.
Yeah, except, with athletes, it does depend on severity of it. It takes on a life of its own. That's what eating disorders are, mental illnesses. And that becomes something that they can't let go of even off season. Okay. So when it comes to, and it is actually, most of the research states with what you're saying, it's like weight class athletes or aesthetics of like swimming, diving, gymnastics. All of these athletes are seen very much with that high risk of developing an eating disorder. I think it's something like, actually, in college levels, about 33% of males are being at risk of developing an eating disorder, whereas 62% of females are at risk of developing an eating disorder. So it's a lot more of an overconsumption of these habits.
Okay.
Mm-hmm.
Okay, so thank you for explaining that.
Yeah.
How do these patients present themselves in your office? How do they come into?
So at this moment, I am actually at the highest level of care. So for patients to come into my office, it is a for sure diagnostic of an eating disorder, and it requires severe intervention because I'm at a residential level. So there's different levels that we step into when we're thinking of any kind of symptoms or suspecting of an eating disorder, right? So there's the first, like to speak, the first step is like outpatient, right? So you're just going into a dietitian, you're just like, some red flags come up, like, oh, you're not eating carbohydrates or this or whatever. Once you start entering into the treatment of eating disorders, there is 3 different levels. So there's like an intensive, which is right after outpatient, where patients come in like 2-3 times a week into the center at night, and they're kind of just working with a team to see if they need higher level of care, which is where I kind of come in, where it's kind of like either an all-day program, so we're talking like 8 to 5, or a residential level, which is where patients are actually institutionalized with us.
Okay.
Yeah.
And that's where you're at right now?
That's where I'm at right now. Mm-hmm.
Okay,
Yeah.
so even with that, you do see the disordered eating?
So with that, we see eating disorders. Yeah. Mm-hmm.
Okay, got it. That understood. Okay, and what would you say the demographics are? Because I know you were talking percentages, but that was pretty much on how likely it would happen for a college,
Mm-hmm.
correct? So what is the demographics for patients that are coming into, maybe not the residential, but the very beginning, the outpatient?
Yeah, so it's actually very interesting, but most of the time when I see patients at lower levels of care is very young patients. Whereas the residential level has, honestly, I haven't been able to put a finger on it. It's all ages,
Wide range.
all races.
Yeah.
So, but usually when I'm thinking more outpatient and thinking more lower levels of care, it's usually more of a younger demographic. And a lot of them have athletic background.
Okay, that's what I was going to ask.
Yeah.
If it was athletic background, and if they're younger, does it tend to be more student?
Yes.
Student athletes?
Yeah.
Why do you think that student athletes, I know at the very beginning we talked about how obviously the training and they have to do this and this, or they consider they have to do this and this to become to get at a higher level. Why do you think student athletes get to that mentality?
Oh man, so I have so many opinions on this. Like
I get it because I was a student athlete myself, so I have my opinions on it too. But
right. And I'd love to hear that actually as well, because I was never really a student athlete. I always dwindled in sports, but I was never good at anything. So I never really like dived into any of that. But from what I'm noticing, right, with my younger athletes, it's such a misconception with nutrition, the wrong people talking about it, the wrong teachers and coaches, and like they have such wrong informations on what they have to do. I've had so many cases that say, oh no, my coach told me I couldn't have a cookie for the entire season. And then you also get into like the idea of family. I think our older generations were really not taken care of with eating disorders and disordered eating. Like we have so many older women and men that have these misconceptions, and they teach it to their kids about like, you shouldn't eat this, especially, we both come from a Hispanic background. There's always that like grandma and grandpa are like, don't eat this because then this happens. So I see a lot of family as well. But if we're focusing only on, at student athletes that have disordered eating, it comes from a miscommunication of real nutrition information that is from, specialized like dietitians. It's just, the health teacher that comes up with, I saw this at, Google, and like social media says that you shouldn't do this or that. And that's really where I see it. It's mostly like someone does not know anything about nutrition and is teaching these girls and these boys about nutrition. Because, when we're thinking about different types of eating disorders, if a lot of it is this thing that it only affects women. And it's not true, especially for male athletes.
Yeah, I mean, there's even the point that it even calls the female triad.
Yeah.
So,
Yeah, 100%.
And now it goes all into that. But okay, so you mentioned at the very end how there's different kinds of eating disorders. Would you be able to just elaborate for those who don't know them?
Yeah. So I think the number one that people think of when they think eating disorder is anorexia, right? So that's like where everyone kind of, oh, an eating disorder, it equals anorexia. When in reality, anorexia is actually the smallest quantity of cases. So just like a little background, right? Anorexia is a very big fear of weight gain, very much of a restriction type of thing. Like they will not be able to maintain an appropriate body weight. They're always losing more weight. And it is the one that is very much linked with kind of like a body dysmorphia, even though all of the eating disorders have some kind of body dysmorphia that could happen. So that one is anorexia is just like an overall restricting of food. Then we have bulimia, which is where there is a category of a type of binge eating, right? So they eat a lot of food at once most of the time, and then they always have to get rid of it. So I think people think like, oh, like vomiting, like purging. That's the first thing that people think of, when in reality, there's so many compensatory behaviors. So we're talking laxative abuse. We're talking over exercising. We're talking diuretics. So a lot of different compensatory behaviors. So those are the main two that people think about. Then there's a bunch, but there is what we call binge eating disorder. So this is characterized with people that overeat a large amount of food in what is considered a small amount of time, where they become kind of like, they feel like a loss of control, like they can't stop themselves from eating. The difference between the binge eating that happens with binge eating disorder than happens with bulimia is that with binge eating disorder, there's no compensatory behaviors. They don't try to get rid of the food in any way. Then we have ARFID, which is avoiding restrictive food intake. This is a little bit different, where we don't see so much of the body image as we see fear of food. So we're talking about patients that are afraid of like choking on a food, or like they have texture issues, or they only have safe foods based on like this food once might have made them feel bad, and for some reason it became this like ulterior thing in their lives, and they're unable to touch that food ever again. So it's more of a what we consider like a pickiness of food. Like we're usually, when we see these patients, they actually kind of stick to foods that you would give a toddler, like chicken nuggets and like French fries, and like, so they feel very unable to do a lot of different textures, temperature, consistencies.
Is that the sensory?
Yeah, very sensory as well. Mm-hmm. So those are usually the top four that we kind of see. And then we have, one, there's different names for it, like OSFID, EDNOS. It just means other specified. It doesn't fall into the diagnostic criteria of any of those four. It just kind of takes a little bit of everything. So it's kind of like their way of saying like, it's something, but we don't know what it is. So,
but it's something.
It's something, yeah.
How do you get diagnosed with an eating disorder?
Yes, so it definitely needs a psychologist diagnostic. Usually it is something that is referenced by, it's usually caught more by a general practitioner. Okay. Like if they have been with that person for a long time, or they come in and they're like at very low weight, and then they start questioning like, oh, like, what are you eating? What is this happening? And then they usually will refer them back to either like an eating disorder dietitian or an eating disorder therapist. But they are diagnosed by a psych, basically.
So that's how you'll get the final diagnosis. But yeah. It starts, you said, as from the primary care, when they kind of hint towards something.
Oftentimes, yeah. It's oftentimes more of like a referral system. Okay. Most people don't get lucky enough to just go straight into psych and say, I'm diagnosed with this.
Yeah, I figured it's usually, that's actually probably now how insurance work too. So
Yeah.
it's like,
Oh my gosh. The
yeah,
insurance.
I know. I know. I worked my past job. I worked with insurances, so I get
Yeah.
it. It's something else. Okay. So I have a question regarding the, how do you approach someone that has such views on the way they eat or the way food is, if it's sensory? How do you approach someone if you're aware of it?
Right. So I will tell you one thing. The way that I approach my RFID patients is like 180 of what I approach my other eating disorder. Because in reality, the expectations are going to be different. We're going from just, whether that be anorexia or bulimia or binge eating, it's kind of like a relationship with food, right? And there is fear involved, yes. But when it comes to they usually are able to get on track with the meal plan, and they're just afraid of food overall just because of how it's going to make them feel or how they're going to change their bodies. Whereas with RFID patients, it's an actual fear of the way that food is going to go down. So these patients require a lot more food exposure. So where I sit down and I have to eat with them the food and see, okay, what are the sensations? Let's be logical. Like, what is really happening? Like, you're not actually choking, or this is happening, or this, it requires a lot more of those kind of exposures. But usually with anorexia, bulimia, all of those other ones, it's really starting with the basics. It's starting with telling them, listen, I know you don't believe me, and I know you don't want to believe me, but you have a really terrible misconception of nutrition. So let me teach you. So and it's funny because I've had patients stay with me for months that for like the first month and a half, they're like, no, you're wrong. This is not real. This is not what I've been told 20 years. And then once they really like lean into treatment, like 2 months later, they're like, wow, like carbohydrates are real. Like I need them. So it's a lot more about first really nipping those bad habits of what they think they know about nutrition, and then moving forward into really understanding, where did your relationship with food come from? Why is it the way it is? And what do you want it to be? Because a lot of times it's patients that are coming to you and they're like, first of all, I didn't even know any of this was wrong. So a lot of cognitive behavior therapy.
Do you ever get overwhelmed with those steps?
Yeah, all the time, because you know why? It's about constant repetition. And it's not just because you're trying to convince someone that you're right. You're also dealing with a very sick population that has a lot of malnutrition. So the rigidity of an eating disorder actually takes place in a physical form. Like, it has been shown that the brain actually shrinks. So they have a lot of memory loss and a lot of critical thinking missing. So it's all about like that rigidity of like, this is the only thing I know. Like, I can't really focus on any of that until I've gotten enough nutrition into them that they're able to start thinking more clearly. So a lot of times, like, I've actually had like some of my most severe cases, it's like, you need to do this because of this. And then like a couple meals later, they're like, why am I doing this? And then I'm like, well, remember, we have to do this. And it's kind of like they need that constant reminder of like, you need to keep going so that we can get to a point where you're going to understand me. But it requires a lot of trust. Yeah.
Yeah, I
Yeah.
mean, it's a bond that you have to build with them too.
Yeah.
It's a whole relationship. So it's understandable on both your side and the patient side.
Yeah. Yeah.
Okay, and let's go back to athletes. How
Yeah. Yeah.
would you say that it affects with the disordered eating or eating disorders,
Mhm.
their performance?
Uh, a lot. So what I notice most of my athletes say is, I actually started this to up my game or to perform better. And it turns out it sucks now. So then it's that relationship that they make these changes because they think that they're going to perform better. For example, I had one athlete that was a cross country runner. So she thought, I lose weight and so I'll be lighter and then I'll be faster. And so theoretically, that makes sense, but then you're missing out on the idea that what's going to keep you running, what's going to build you need to build this muscle, which you're actually just wasting. So what was the question? Because I think I was going to go off on that one.
No, it's okay. So the question was, how would you say it affects the performance on athletes?
Oh, yes. Okay. So then it usually impacts in a negative way. They usually run out of energy. Their performance tanks based on their ability to upkeep their training. So even though they might perform at like actual events, right, like track meets or games or whatnot, their training begins to become like deficient, like during actual, like, you know, the long trainings, like the practices and whatnot. They're not able to keep up with the rest of their team members.
You can see that also with the ones that are binge eating.
You know, it's actually very interesting. When it comes to the binge eating, I haven't seen solely binge eating in athletes as much, because it's often followed by compensatory behaviors. So it becomes this kind of cycle where, and this is actually right, like when we're talking about this, it's like a brain-gut relationship. And the way that this works is when restriction goes up, right? If we become afraid of a food or we restrict a food, you're giving your brain the pathway that thinks, okay, we can't have this. This is making us freak out. And also, when you allow me to have it, I'm going to have as much of it as possible, because you're going to not let me have it again. So it becomes that binge situation that whenever you have that food, you're going to lose control. But then with athletes, I often see more like they restrict because they're trying really hard to keep to their diet so they can meet the goal. But then they're hungry because they're wasting so much energy that they get to a point where they're like, I need all the food. So then they'll eat all the food and then they'll go work it out again.
So I was just wondering if you saw that, and if there was any type of negative or any other type of, on their performance.
You know, I think actually you bring in an important factor that I hadn't thought about, because I think that there is a misconception that athletes should be eating the same as everybody else. And if they're eating more, then they're binge eating. And that is 100% false, right? So they eat a lot, and then people tell them or they think they are eating too much because they're not eating as much as their non-athletic friends. And that's one thing that my patients struggle with, that are athletes, when I tell them, listen, the reality is that you are going to just need more food. And I know you don't want to accept that, but you're going to have it. So I think that there's also a very fine line between understanding that athletes at a baseline are just going to require more food.
Yeah, that's you should go in already with that mindset.
Exactly.
At least. I'm actually, I understand that for you, it must be very repetitive, and I give you props for speaking and handling properly your patients and everything, because with my coworkers, I get frustrated and all that. So I completely understand, and good job on that.
Thank you. Oh my God.
So one more question, and you can provide any additional information. What is the recommended treatment for athletes that come in with disordered eating, even if you don't see them at the residential level, but they're coming in for outpatient, or the ones above?
My first reaction would be get someone that's qualified to deal with this, because that's really the deciding factor. Because I find even in our own field in dietetics, there's a lot of dietitians that specialize in sports nutrition that cannot see the symptoms of a developing eating disorder. So they're focused a lot on what's going to make this athlete get to the next level, and they're ignoring, I wouldn't say ignoring, but they don't have the ability to realize, well, I am really changing the way that their relationship with food is.
Well, it's also not their specialty. So.
Exactly. So I think that when those red flags come on is to not ignore them and instead refer to someone that can help them better. Because the reality is that eating disorders are very treatable. It takes a long time and it's a long process, but they are treatable. But the quicker we get them, the better the outcome. So for student athletes that are starting to bring up these red flags of some kind of disordered eating, it's pulling them aside and saying like, hey, like I think that you need to see someone about this. Like, I'm not saying that you need to go residential and like go crazy and you have an eating disorder for sure, but it's kind of like, let's see where your fear is coming from. So that either way, I want to support you in getting the goals that you have athletically, but I don't want to put you at a risk of a long-term eating disorder.
Okay, and what's the step afterwards? It depends, obviously, with patients and all that, but what would be, I don't know if you could give an example.
So, but what do you mean? Like if someone wants...
So if you already take that step forward and you find someone, if I'm coming to you and I'm telling you, all right, I went through my PCP, I went through psychiatric evaluation and everything, and I'm diagnosed with an eating disorder.
Yeah.
Now what goes forward? Like, how do you approach the patient in providing their treatment?
Yeah. So once they are diagnosed with an eating disorder, a lot of times everything in their life has to take a step back, including that sport. So that's why we typically don't get a lot of commitment with them, because they're like, you want me to stop what? Mid-season? No. So unfortunately, if it becomes an eating disorder and it becomes something that is kind of over consuming their life, sometimes it is recommended that they take a step back from that sport and they get the help.
Okay. I mean, that makes sense because it's a full-blown force that you have to just kind of reckon with. You have to learn to handle and kind of like rewire yourself to go back into it. And when they do finish their treatment, how long, I know you said it does usually take a long time, but what, do you have like a general?
Yeah. So depending on the severity of the case, I usually see, of course, insurance always wants to cut out quick, but typically we do see patients stay in the residential level for about 2 months, more or so. Then they step down to right after. What we do know evidence-wise is if we were to step down patients from residential straight to outpatient and just let them go, high chances of them having to come back. We want to reintroduce them to their lives at small increments. So from being in our facility in residential for 2 months, like 24/7, we want to step them down to something like a day program where they come in at 8 to 5 and then they go home to sleep, or they go home to have dinner with their families. And then that usually, we do recommend minimum of 6 weeks around for that one, depending on insurance again. So after that, we then go into about 3 nights a week. So this is more like, okay, let's get back to your life. You know, you have college, you have class, you have work. So they typically have this level of care at night. So like 3 nights a week, something like a 5 to 8, where they just come in 3 times and they're like checking in, having dinner with specialists and whatnot, to kind of making sure that they're continuing their programming. And they do have the tools to not be engaging in behaviors. And then after about 6 weeks of that as well, then usually we discharge them to outpatient providers where they see a dietitian or a therapist or a psychiatrist once every 2 weeks or once a month.
And what's the evidence on that once they go through all those steps?
Usually, if they are able to go through all those steps, it is actually a very good transition, and there's a lot more long-term success. When they start skipping around, and I have, unfortunately, like insurance cuts out randomly, and like I have a patient that stepped down to day programming, and then in a week they want them to be just a night. We see a lot more stress, because think about it this way: when they're in residential, it's like a bubble. They're not in the real world. They're 24/7 with therapists and groups and talking about their eating disorder and having meals with staff, to like then throwing them back into like a workplace that's diet cultured, and going back to work and being around family members that don't shut up about their diets. So that success is not there.
That's unfortunate.
Yeah.
Insurance sometimes messes us up when we don't expect it to. When
Yeah.
we thought it'd be helping us out, it kind of just flips it around.
Yep.
Is there anything else you'd like to say regarding disordered eating or eating disorders for athletes or overall? Because we did speak about everyone in general.
Yeah. I think the only thing that I would definitely want to mention that I feel like I'm always screaming at the top of my lungs about is break up with diet culture. These people need to stop basically preying on the body image of these poor individuals. Like, it really is so horrible, the stories I hear. And sometimes it's not even people in their lives. It's about magazines and social media. And, or the health coach that has 300,000 followers that told me to water fast for 5 days a week. It's really bad. And here's the thing, like
that one, so
my gosh. And the reality is that not all disordered eating becomes an eating disorder, but disordered eating has a high risk of becoming an eating disorder. And that's the reality. And when we start leaning into people that start one diet and then start another diet, and then you see the symptoms of, oh no, I can't go out to eat with you because I'm like on this strict thing, it becomes over consuming. And that's where, like, I think a lot of what people need to hear is, if it's not a dietitian, you need to take it with a grain of salt. And even dietitians that are not specialized, sometimes there's always, like I always tell everybody, there's always a few bad apples in every specialist. So
that's very cool.
Yeah.
Okay, Ale. Well, thank you for taking the time and speaking about all of this. Sure. It was actually an eye-opener for me too, because I've read my certain parts of pieces and everything, and I've also experienced it firsthand, at least in the athletic side. And you are completely correct with everything that you have said, obviously. Even if patients tell you you're wrong.
Yep.
Part of their sessions. But I wish you good luck and the best of luck with everything that you keep doing, okay? And I hope we can have a couple more talks like this.
For sure. Always here.
Okay. You have a good night, okay?
You too. Bye.